Good morning, everybody. How are you? I'd like to welcome all of you to the Mount Sinai Cardiac Cath Lab on this wonderful day before Thanksgiving on Wednesday. We have a limited team, obviously, because of the Thanksgiving break. And so our moderators, Dr. Kapoor and Dr. Guja, are out. And we're fortunate enough to have our very good friend, Dr. Atul Kulkar, who's been with us for most of this year, and he's the director of cardiology at Mount Sinai Queens, our sister hospital, and a very talented peripheral interventionalist is here to help us with this complex case. Just some shopkeeping news because of the holidays. Our next peripheral webcast is December 17th at 8 a.m. Obviously, because the Christmas holidays or the holiday season is the week after, and a lot of us are going to be out. And also, this is a week early than scheduled. And a recording of today's live case will be available today, as always, at ccclivecases.org. Unfortunately, today we will not be able to take any questions, as just me and Dr. Kulkar are going to be doing this case live. But again, to introduce, he's to my right. This is Dr. Atul Kulkar, the Chief of Cardiology at Mount Sinai Queens. To his right is Dr. Haroon Cameron, our endovascular fellow for this year. Behind me is Ray Lascano, our endovascular nurse practitioner. We have Damien Cabrera, our talented CV tech, and Elizabeth Holton here, who's always with us for our live cases. We have a very interesting case that was failed elsewhere and as well as here, which we're trying a new access technique to be able to get through. And I'm going to let Haroon take it away. Haroon?
Presentation, please.
Presentation, guys.
Hi, good morning, everyone. Next slide, please. So our patient is a 68-year-old female with a past medical history of hypertension, diabetes, dyslipidemia, smoking, and a history of PAD, who presents with left greater than right lifestyle-limiting claudication that has progressed to pain at rest despite medical therapy. Her medications include aspirin, metoprolol, lisinopril, atorvastatin, cilostazol. As part of the non-invasive workup, she had an ABI with exercise done. As you can see on the left, the ABI from rest 0.92 dropped to 0.67 on exercise. Patient had a ultrasound done that showed in-stent restenosis of the left SFA. A subsequent angiogram was done that confirmed left SFA in-stent restenosis with an unsuccessful intervention attempted. And now she's referred for further intervention at Sinai. Next slide. As you can see on the left, there's a left lower extremity runoff that shows an occluded SFA. And on the right is the DSA below the knee that shows one vessel runoff. Next slide. So our initial tentative strategy includes getting a contralateral CFA access versus an ipsilateral pedal, or you'll see the other attempt of the access, a glide wire with catheter support for entry, a true lumen versus subintermittent tracking and re-entry to enter the lumen, switching to an 014 wire for intervention, possible filter placement, atherectomy, and then subsequent angioplasty.
So this is an interesting case. You do not have pictures of the last one, right?
We have. Can you go back?
Go to the next slide. So this is an interesting case. This is a patient who we had come into us with an occluded SFA stent. So you can play it. So you can see here that you have antegrade access, up and over with a 6 French sheath, and then you can see that the runoff, it's not playing, but the runoff for whatever reason is not playing. But I can show you. Anyway, can you go to the next slide? Yeah, there you go. So there you go. So you can see it's an occluded SFA stent. So we had a lot of trouble finding the ostium, and you see that you have a gap between the two stents. And when we tried to get to the gap between these two stents, we could not, we were not able to cross into the true lumen of the next stent. So come to live, please, live Flora. So you can see here that what we did was we went ahead here and we got contralateral access again. We went with the 7 French system. And you can see here the runoff again shows the ostial occlusion of the stent, followed by a distal reconstitution at the level of the above knee pop. Is actually, which also has a short occlusion. And then no, actually that's the distal SFA that's occluded below the superior stent. And then you have the below knee pop reconstitutes. Then you have a distal runoff, which is via the perineal artery all the way down to the foot, with no real access below. She's a severe incapacitated claudicant who's failed maximum medical therapy, whose current only option would probably be a bypass. She does have a good DP and PT that's reconstitutes via collaterals from the foot. So we went up and over. You can see here, we're just gauging this. I'll come back to that. We went up and over, crossed into the stent from above using a wire catheter technique, then looped the wire down. And then when you loop the wire down, we were unable to get into the stent. You can see we're outside the stent. So at this stage, we decided to go ahead and use fluoroscopy to go ahead and puncture the stent. We puncture the stent, and we now have a needle in, and we have the wire up. And you can see here, we're actually very, very close to this. So now what I'm going to do is I'm going to put a snare in, and I'm going to snare this wire because this wire is quite destroyed. Can I have a snare, please? Yeah, give me a 10. So we're going to put a snare in, and then we're going to snare this wire out, and hopefully we'll be able to get it. If not, what we might have to do is to put a sheath in, and it might have to cross from below with an 035 wire. Currently, I just need a regular wire, guys, here, a woolly wire. Currently, I have a aqua tempo up and over with my micropuncture sheath down below in the groin. Can I have my woolly wire this side? So what I'm going to do now is I'm going to exchange my aqua tempo out for my snare, which is going to occur right now. So my aqua tempo is going to come down right there, and what I'm going to do is I'm going to go ahead and load my snare. So I need my snare catheter to go in here. So what I'm going to do is take the snare down to the level of this wire. And I really don't know if I'm in the right plane, but we were sort of interacting with the what is it called, the wire with the catheter from above. So here's my number 10 snare. Yep. So there's a number 10 snare going in. Oh, the wire came back. Let go of the wire, please. Hopefully it didn't come all the way up. There it is. Great. So we're going to take our snare all the way down. A lot of resistance here. Show me above. There it is. So we're just going to push our snare down. Hopefully it goes. Doesn't seem to want to go here. Huh. So you also got to be careful that you don't push your sheath out as well, which is part of the trick. Put positive pressure there, Ray. So we're going to have to just hold this and then try to push our snare as a system here. Doesn't seem to want to go, or does it? Nope. Kind of wants to go, but doesn't want to go. All right, so give us a... Yeah, I don't think the snare is going to reach unless we get there. All right, I'm going to need a balloon, guys. I'm going to need a balloon catheter. I'm going to need a... actually, give me a 014 Spartacore here. Show me above, Ray. Yep, give me a Spartacore wire. Yep, we're going to go with a Spartacore wire. We're going to balloon our stent track. So some of these ISR cases can be very, very resistant. Give me a 50 Vitrac balloon, please.
Right?
Yep.
That's a command.
Spartacore wire, please. And a 50 Vitrac balloon. I'm going to have Dr. Kukar go ahead and flush this out for me while we go ahead and get this started. Once the snare comes out, we're going to balloon the track inside the stent, even though it's occluded, to allow our snare to go down. For whatever reason, our aqua tempo went with a lot of resistance, but the snare is not going. So we're just going to loop this wire. I hope it goes. All right, give me back the aqua tempo. Okay. Give us a Navicross, guys. All right. There's a lot of resistance. So, you know, this is sort of an attempt at revascularizing. Here's a lady who is very, very debilitated. But this distal common femoral access is definitely a unique way of being able to get in, a distal SFA access, a unique way of being able to get in. unfortunately, with this much fibrous tissue, you got to wonder about how we're going to be able to keep this open. I'm going to make sure that we go right into the stent again. Rail, pull it to me, Art. So we're going to go right in. Let's leave it right there for a second. Yep, it seems to be going really smooth there. So now I'm going to have Dr. Kukar just allow me to just push this down, or give me the 035 glide wire again.
Yeah.
We're going to have to get a new Sparta cord. This one's destroyed. Yep. Glide wire.
It's wrapped up.
Yep.
So Art, in these kind of difficult cases, when you don't really have a pedal access option, this is something that obviously you can try to do as well to be able to get this. Have you done this technique recently, or have you seen it? Have you thought about this kind of stuff in these kind of cases?
So it's interesting. Initially, I think at some point I would have tried pop, but I think this is too dangerous to go because you're a single vessel.
Yep,
but I think the I would usually try to go distal SFA past the stent, but there is no distal SFA past the stent.
Right. I wonder if the snare is not going to fit through here. No way. So give me the command wire now. So I'm going to go with a command 014. 014 command wire, please.
Yeah. Should be the command wire, right?
So we're going to put a command 014. We're going to balloon this, and then we're going to take the snare down. So yeah, in the old days, Art, we used to do a lot of pop access in these kind of cases, and I think definitely this technique has changed that a lot. You know, it's more comfortable for the patient. You can see the patient is really relaxed on the table as we speak, and then we're going to try to just pull this out as a whole.
The balloon.
Other thing also, we've now created a lumen from above, right, to come down. So it's interesting that our snare won't go, but this will go, huh? It's kind of interesting. So maybe
I think the other advantage of doing this and not going to the pop is you're not burning any bridges.
Right,
If it
exactly.
doesn't work, it's okay.
Very good point.
If you burn
Give
the
us the
pop,
5.0
you're
Viatrack, guys. So we're going to go with a Viatrack. It's an 014 renal balloon. That's a very good point. So a lot of people have been going to pedal first in these kind of cases, which makes sense. But this is a good technique if you can't cross the stent. You have good pushability, and you're able to go ahead and get this in. So let's see whether we. No, it's a monorail balloon, and this is a nice 014 Abbott monorail balloon, which really works well. So what I'm going to do is balloon my track to get this down there. Anticoagulation-wise, I'm on heparin, so I can reverse, and I've got my micropuncture dilator only through. So you can see even this wire seems to go behind the stent. Is that behind the stent, or we got in the stent? That would be great. That would be hilarious. No, it's behind the stent. Yep, you can see it's behind the stent. Okay. So now we're going with this balloon. So I'm just going to balloon over here. Yep. So we're going to balloon the track to be able to get back in. Eight down. Okay. Over here. Down. Right here. Down. Here. So this is more like watching paint dry.
Both of them were.
But we need to go ahead and get the track going, or go to 10 Art. We need to really get the track going here for us. Yep, over here. Go to 10. Because we want to reduce the resistance to pulling the snare out 12. Okay, down. So now we've definitely confirmed we're within the stent without a question. Down. Yep, there's probably a tight spot right here. Down. You can see it's all really fibrous ISR that we're dealing with. 12, 14, 16, 18. Down. Over here. It's probably the reason we had so much resistance. Down. Right here. Ooh, down. What's that? Okay, give me that other snare now. So hopefully this works. What's going on, Liz? Anything with her? Talk to her, please. Oh, she's knocked out. Okay. So, can I have the snare catheter back? So now we're going to go with the snare catheter. So I mean, other than this, I mean, if this doesn't work, I think then obviously we're going to have to just relegate her to either surgery or medical therapy, neither of which I think are ideal for someone like her. So here's our snare over here now. So now what we're going to do is we're going to go ahead and introduce the snare. Now, if we didn't have a destroyed wire, we could have done something a little bit different. Sort of, you know, be able to steer the wire in, but we've damaged the wire quite a lot to go all the way down there. So let's see what we can do here. So we're going to introduce our snare in. And we're going to go down and try to interact with this. So hopefully, I think the catheter was interacting a little bit. Hopefully it continues to interact and we can grab this with the snare, which is what I'm hoping for. So let's see here. There it is, okay. So you can see this, Flora saved that. So you can see the snare is definitely interacting. So I'm going to push the snare further down here and then come with the catheter over the snare and try to grab it. No, looks like we got it. Okay, now feed it right for me. Okay, no, this one. You need to push the wire. Go. Okay. What's going on? I think I lost the snare. Yeah, we're still there. Okay. So we're just going to pull this out. Oh, there we are. Okay, we're out over here. So now what we're going to do is we're going to externalize this wire. So Ray's going to continue feeding this through. Yep. So I need a guide now, guys. Give me a 6 French guide. Watch out for this. Yep. Get 6 French multi-purpose guide. So now we're through and through. So I want to show you where we are. We're within the stent, see, and now we're through and we captured it outside. So now Ray's just going to clamp it like we normally do. And I'm going to go with a 6 French multi-purpose guide.
Want to cut this or?
Yeah, I mean, you could. I mean, it's a guide, so it shouldn't be a problem. Now, the reason I'm going with the 6 French multi-purpose guide is I've got this, you can see I snapped something there, which is on that thing. I think Dr. Kukar is going to have to cut this. He's right. You're going to have to cut this. So I'm going to hold this. Can I have a forcep, another one? That's fine. Here. So that's it. So now Dr. Kukar is going to backload this onto the 6 French guide. So that's one of the reasons I went with a 7 French sheath.
Goes on it, right? Combine it or no?
So while we go up, he's got it now. So I'm going to go down. And again, really, there's going to be a little bit of bleeding until I enter the stent, which we know is occluded. And then you're going to see what I just did. So I'm just going to sheet this. I'm going to go all the way out into the stent here, right? Now I'm definitely in the stent. Now what I'm going to do is I'm going to have Dr. Kukar just pull this wire out on this end. Ray, can you just pull? Yeah, just pull that wire. And I'm just going to keep it here. Pull. Excellent. Okay. Then what I'm going to do is, now that I'm here, Now I'm just going to double check, make sure I'm within the stent in every different angle, right? I'm definitely within the stent. I got everything out. I've got some sort of goober over there, which I'm going to have to suck out through my guide, which I will. So, no, okay, so it's my sheet tip. So I'm going to have Ray pull the sheet out. It shouldn't bleed. So we're just going to pull the sheet out, as you can see here. So sheet is out. Hopefully that goober is out too. And the goober is out too. So we're good, okay? So now we're just going to hold a little bit of light. No, I don't even think we need to hold. There's going to be nothing there.
Yep.
Now I need my 035 wire. Oh, I just need my 035 glide wire because now I'm within the stent. Now I have to start working on what to do to cross this. So, I mean, Atul, at this stage, we could take a little picture here. Let's do a little DSA. Make sure we have a good pressure, right? A little DSA action. Right. So our DSA shows our distal target right there, right? So at least now we're in the distal target. So now we're going to have to try to do this. Can I get a new wire, guys? This one's really messed up.
So PK, at this point now you're in the stent.
Right.
You have to guide, antegrade.
Right.
You're coming down. Would you go to an 014 system and try a Confiance
you could.
12
you
or
could.
Sato?
To me, the stent is occluded. I think you can go with an 018 wire. You can go with an 018 command. You can go with an 018, connect 250T, whatever it is that you want to do. I think the point of this case, if we're able to succeed, would be, we're still not out of the woods. We still got to cross this Sapera, which unfortunately occluded, and like all things can occlude. And I think the issue here is what can we do, right? So I think we still got to get through this. If you can give me a little bit more mag. So what we don't want to do now is by mistake get out of the stent. One more, please. So I want to be very gentle. I want to come out with a loop if I can, praying that I do. I would not be happy if I didn't come out with a loop, but let's see. So there, so it went very smooth there. So now I'm going to go ahead and have Atul just do a roadmap for me. Okay, inject. So again, you've already done the really hard stuff now, right? You've already gotten through the stent. Now, God willing, that this will just glide through for us, which I hope, right? And it seems to have just done what we requested it to do, right? So now we're through. Save that, Flora, save that for me. Yep. So now we're going to switch back out to our aqua tempo, or our, not our aqua tempo, but let's not, yeah, I guess we could track this down. I just want to make sure we're in the right vessel just to see where we are. Show me a little lower, Atul. Yep. I just want to go ahead. Yeah, we're definitely in the vessel here. So I think I'm very happy. So now we're just going to go ahead and get the aqua tempo because it's an easier trackable catheter. So I'm going to walk this one out. Ray, fix my sheet, please. So a lot of resistance. She's having a little bit of pain, I think. Okay, she's fine. Okay. Okay, give us the aqua tempo, please. And then what we're going to do is we're going to put a bare wire down. Bare wire. Get us a bare wire and an ember shield. Todo bien, mama. So, I think that this is a nice little elegant trick to be able to work on these. It's just another little skill set that we hope to teach you in our live webcast. Again, I don't think we'll have a trouble getting through this area. Show me down.
Now, PK, how do you handle this? Obviously, there's no bleeding and the thigh looks great. You have a heparin on board. You're keeping your ACT closer to 250. And
right. So usually over here, Atul, you just balloon tamponade on it. It really shouldn't bleed because it's an occluded vessel. But we'll see how she's got good blood flow back, no hematoma, right? No, good. So usually just a balloon tamponade is all you're going to need. What's happening? Okay. Can I have a bare wire, please? So we're going to put the bare wire in. We're going to put an ember shield. And what we're planning on doing here, Atul, is doing a laser followed by a DCB and definitely stent. We're going to have to stent this. So those of you who don't use the Abbott Ember Shield, this has now an FDA what is it called, an indication for fempop atherectomy. It's a device that is actually well suited for these kind of tough up and over cases. Show me down, brother. So let me just see whether we can. Yep, there it goes. Yep, so I'm just going to take this all the way into the foot. That's good, more than enough, yeah. So we're just going to go low mag here. And now we're going to get the embo shield going. So at this stage, she may have a little bit of bleeding in the thigh, but I doubt it, but you never know. So we're going to get the 4-7 embo shield in. Okay.
And now, how would this change if you had 3-vessel runoff and you're doing this for one or the CTO?
Oh, definitely, yeah. I think it definitely would change. I think you could have gotten pedal access. Can I have the embo shield, please?
Yes.
We would have gotten pedal access. We could have gotten, we also can use different therapies such as a Viabon stent as part of the Reline trial. We could also do that. Can we do it sometime today, please?
Right. So with the single vessel runoff, we consider that a Viabon is not the stent.
Well,
it's
not an ideal stent with single vessel runoff.
Right.
Can you undo this for me, please? Ray? Thank you.
Okay.
So the embo shield goes on the bare wire. So we're going to remove the wire that the embo shield comes with, that Ray is pulling out right now. And then we're going to go ahead and load the embo shield on.
And this is a 4-7, correct?
Yep. So there's a 4-7 embo shield. Thank you, bro. So 4-7 embo shield. It's a monorail system. So Dr. Kukar is going to grab it there. So he's also going to check to make sure that I didn't screw up and I have the tiger stripes on that end of the wire, right?
Yes.
Yep, the tiger. You could also run your fingers through to make sure, and Ray's going to set up our laser here. What I may do is quickly angiojet this just to make sure we have no clot. Can we quickly angiojet, guys? So we have no resistance going down right now. I'm going to deploy the filter right here. So you can see here the embo shield is here protecting my single vessel runoff. I'm going to walk this out. Actually, you know what? Let's not angiojet. Let's just laser. I'll tell you why, because laser also has thrombectomy properties. So let's go ahead and do that. So we're going to go with a 2-3 laser. I'm just feeling her thigh, which is a little sore, which we expect it to be sore. And then we're going to go ahead and do what we need to do.
One thing, PK, this is one of the cases where you don't have a good nub, although you were able to get through the proximal end of the stent pretty smoothly.
Right.
Sometimes, have you ever used a laser when you don't have a nub to actually create a small
right?
nub?
Not 2-3, I'm sorry. Yeah.
To create a small nub when you have flush SFA occlusions?
Well, this is another technique when you have no nub, you can come from below, and you can try to get through. There's another technique that you can use also. But I think in this situation, especially with ISR, your catheter and wire tends to be deflected into the profunda, which is going to cause this kind of issue. But sending her for a single vessel bypass, for a bypass with a single runoff vessel with a below knee target is not ideal. If we can salvage and not, like you said, extend our intervention into the below knee, then I think we've done her a service with DCB. She hasn't had DCB yet. It's a very old stent, as you can see, very fibrotic. It's not really something that's going to work. So therefore, I think this is the situation where this will be very, very good for her to give an endo attempt with drug-coated balloon. She's been consented for drug-coated balloon, and so therefore we're doing it. Is this calibration okay? Yep, ready? Okay, good. So we're going to go with it. So Liz, I guess we haven't done a laser in a while because we don't have the venous set up yet. We don't have any of that set up yet. So we're going to have to do all that in a second. I don't know, maybe it's Thanksgiving Eve and everybody's a little hypoglycemic. Not sure, but Haroon definitely was. So, we'll...
Right, and the key is you want to have a constant pressure saline flush as well.
Right, exactly. With all kidding aside, you definitely want that to be done. Okay, so I'm just going to go ahead and advance this. Yeah, I don't want... don't pull the wire.
One second. Let's just watch that.
Just watch our filter. That's the key.
Yeah.
So just rail the wire now. Keep the system straight. Nice rail on the wire. Thank you. That's good. And then once we get it there and once Liz gives us the saline flush, we'll be ready to start. The other thing you can do is you can flush through your sheath. Just hit the saline for me for now and flush out the sheath. And you can see here all this dye has to go or else you're going to get laser explosions with this. So you need to flush all this out. So Artie's going to keep flushing it.
And I think the other key is using a 7 French system.
Right.
Sometimes, we go in with the 6, thinking the laser does fit through the 6, but the reality is you want the extra space for the flush.
Right, exactly. Well, I generally go with the 7 in these tougher cases because, you know, it's definitely not something that's an easy system. Yeah, I'm just going to do it fluid to fluid. Okay, good. All right, ready? 45, 60, 60. Okay, on. Okay, I got it, brother. So you want to do it as a one-hand job if you can. Ready? Atul, if you could step on the pedal, bro. The laser pedal. No, let him do it, please. Okay, ready?
Yep.
Okay, go.
On.
You want to go very slow with the laser, right? You want to create the vapor bubble. And the larger the vapor bubble is, the more ablative properties the laser will have. So we're trying to get that vapor bubble going. And having, you know, because we ballooned, we're really not having much resistance, which is fine, but you still want to maintain your technique. Because your technique, your ablative technique, is going to be a big deal here. Again, sometimes there may be some heat in the leg, which can occur, where she'll have some discomfort, but that's okay. And also your rate of lasing off. Your rate of lasing will also help you with the embolization as well. On, please. So I'm going to skip that middle stent part because it's an extremely dissected area. And I'm just going to lase the 2 stents.
And so, PK, while we're doing the laser, it's, you know, obviously the other atherectomy devices do not have indications for ISR.
No.
Yet in the coronaries, you know, sometimes we have ISR, we'll rotablate.
Yes.
And what are your feelings on that? Obviously, TurboHawk, I think, is the most dangerous.
Yeah, TurboHawk is contraindicated in this particular manner. The Jetstream, you can obviously use that as well on. That's got data in ISR with DCB. Nick Shamus is currently doing a study with Jetstream and DCB in this particular indication. So I think you're definitely going to have more data out of Boston Scientific with that. Off, please. So now I'm going to take it to the next stent, right? I'm just going to track it down into my supera, right? Okay, and then start again, guys. So again, go through my supera very slowly with the laser. Okay, off. So whenever they move, that means something is going on. I'm going to have Ray feel the thigh, make sure everything's okay, Ray. You know, Ray's going to just feel the thigh. Okay, on. I mean, now we've created a communication channel, so she could bleed. So Ray's just going to feel for anything. Off. So he's going to let him squeeze the thigh. Everything good? Okay, on. A lot of times they feel the heat of the laser, and that might be the reason. Off. Okay, now I'm going to have Atul just walk this out by watching the filter, yep, and the wire. Okay, you can just walk it out without pushing the wire, yep. So this is a very important thing that Dr. Kukar is doing.
A little resistance, but it's coming.
Yep. It'll come, yep. It'll be tight. Yeah, 6.0 long balloon first. Let's get a 6.0 long balloon, any balloon. 6.0 200 Abbott balloon. So I'm going to take a picture here and then see how it looks. Again, always look at your filter first to see if there's any issues with the filter.
The machine.
Okay. Guys, unplug the laser, please. We're done with the laser. So Dr. Kukar can come out. You're almost out, buddy. It's fine. He'll unplug it. There you go. You're out. You're out. Ready, Ray? Fill the catheter, please. Okay, great. Wonderful. Okay, DSA. Okay, inject. So yeah, we filled it. We filled our catheter up a little bit, which we expect to do. So which is fine. No mueva, mama. Let's make sure she's not bleeding here. Inject. No mueva. Inject.
Okay, thank you.
So no bleeding, which is really good. Okay. So let's go ahead. We're going to go ahead and balloon now.
So at this point, you leave the filter in. It's got some.
Yeah,
some
yeah,
junk
we're going
in
to
it.
aspirate the filter and pull it out the way we want to. So we're going to go with a 6-0 balloon here. Don't pull the wire, please, Cameron. And we're going to go down. And we got to be very careful with that filter now, obviously. I know that Haroon knows that, and we're just going to go very, very closely. We're going to go just close to that. Okay, let's balloon right here. So she's going to feel a little fullness. I'm going to let Damien know to let her know. Can we check another ACT, guys? Negative. Okay, go up. There's our 200 balloon. So as Ray goes in and gets the ACT, we'll just go ahead and balloon. Poquito dolor, respira con su boca, respira con su boca. Okay.
6.
7, 8, and expand it. 9, 10. Respira, mama, respira.
10.
Respira. Respire, respire, respire. Go a little higher.
12.
Okay. So we're going to balloon this area with a 6-0 balloon till 12 atmospheres. Got very good expansion, which is good. Heart rates are good. You always want to watch for vagal in this kind of situation, especially with a low resting heart rate. Got an excellent nursing team and obviously excellent tech team here, and I think it's important to watch for that. Down. So now that we've expanded this, she's going to have to feel it one more time with the DCB as well, and we know that. So she, we're going to come back up with this balloon now. Let the balloon deflate.
6 so long.
And Ray's just going to hold the sheath as I pull it back. They like to right about here. Go up here, guys. 60250.
I can personally vouch for the importance of holding that sheath.
Yeah.
A few months ago, I had a left CFA sheath.
Respire. Go to 10.
Damien?
Really need to expand this 12. Respira. Liz. Okay. 12. Okay. Okay. Great. Okay. Down. All right. So we've now expanded it to the best of our ability. And now we're going to walk this out, and we're going to make sure we didn't perforate.
What is it?
Which again, we were very subintimal in that distal area, so we do have to be a little careful. You can see the filter has not moved, so just going to be really careful. Might need to penumbra suction that filter now. We'll take a look, because don't be surprised if we don't have any flow. As long as nothing embolizes, we're okay. And as I did suggest, we're not having any flow, as you see, right? So there's obviously massive embolization that we did expect. So give us a penumbra, guys. This is where your ACT is very, very important. And there's our distal flow and our filter protecting it, as we talked about. So the filter is very, very full. So the wire came back, so I'm going to go ahead and push the filter wire back down. Okay, penumbra, please.
What is the IM guide? Guide.
We didn't have IM, we had a multipurpose.
We need it, right?
Penumbra, please.
Setting. The guide.
You can give me the 6 French guide if you want.
Yeah, that's what we with the multi-purpose, right?
Where's Damien?
He's gay.
Oh, so we're going to go ahead with the penumbra catheter and we're going to start sucking it out. We're going to use the 6 French guide to really aspirate a lot of it.
This is our end, right?
No, we got the catheter. We're going to use the 6 French. Actually, this one's destroyed. Give me a new 6 French guide, please.
That's fine. Give us.
Or you can give me a 7 French guide, Damien. 7 French multi-purpose. So since we have a 7 French sheath, we're going to go with a 7 French multi-purpose. Liz is checking the ACT, and we might give another 1,000 as there's a lot of embolization at this stage. And we're going to go ahead and aspirate it out. So, you know, there's going to be a lot of aspirative material coming out. So we're just going to go ahead and do that as well. ACT is over 200 now. We'd like to hopefully keep it around 250 to 300. Thank you. So here's our 7 French guide for those of you who haven't used the penumbra. So what I'm going to do is I'm going to go take it all the way distal. I'm going to watch for the flow all the way down. Okay, the key here is not to dislodge this filter. So we are going to allow for some bleeding. Oh, there looks like, what is this? Looks like it's like a perforation. Yep, we got a little perforation going on in the front here. Okay. Okay. Yep, we're going to have to balloon tamponade this, guys.
We have the 6-0 back.
Yeah, just hold some pressure, direct pressure, Ray.
A little higher, a little higher. A little higher.
Right over here.
There you go. Yep.
Okay, just hold there. Okay. Okay, let's attach the penumbra now. No, not now. Yep. I'm just going to ask them to give a little bit of dye. Don't pull the wire, please. Very important not to pull the wire. Okay, turn it on, guys. Okay, good. Excellent. So we're just going to go forward. Okay, just going to suck everything out. Show me the distal filter, please. So what Ray's looking for is flow.
Flow, yeah.
Right. Okay. Don't worry about it. Just show me distal. Don't worry about anything. Huh? Okay. Slow down. Okay, now I'm gonna need another wire, guys, here. I'm gonna need another wire. Give me a command wire here.
There's a confidence zone, right?
Give me a wire introducer.
Wire introducer.
Yeah, I turned it off.
Can you drop another wire introducer, please?
Yeah, get me one more.
So what I'm gonna do now is I'm gonna clear the edge of my catheter with another wire and use it as the separator. Okay. Keep pressure. Okay.
I think he's gonna pull it on suction.
Very good. It's flowing again.
Yeah, he turned. Keep it up.
So I'm just gonna go ahead and separate. So right there. Separate. Don't pull my wire, please. Okay, I'm going to come down a little bit further with this. Flowing. Very good. Using the separator to separate this out. Now I'm going to walk everything back, and Ray's going to tell me how the flow is. Okay, now show me which is my ambush shield wire, guys. So I've got to watch my ambush shield wire. Flow is good, Ray. I'm going to come back down, Ray. I'm going to go back down a little further. Okay. So I'm going to just torque it away from plaque, if there is plaque, like right there. Looks like there's something there, which is my embouchure wire. This is.
Correct.
So I'm going to go here with this. Okay.
So PK, you made a very interesting loop on this wire.
Okay, good. So now we're going to turn this off for a second. Okay, now give me some dye, guys. I want to see what's going on with my filter. So I'm going to inject very, very slowly. I'm going to do a road map mag up.
Contrast.
Here.
Oh. It's off, Ray. Okay.
How do I open?
Can we disconnect the
Don't move, Ray.
flush? Can you turn the flush off?
It's in.
Just want to see what we're dealing with the filter here. This is not dye, guys.
That was
I don't
the
know
die.
what this is.
That was the die. Damien, that's the die, right?
Press it on and off, please, roadmap.
That's the die, right? He's saying it's not showing. It's probably too dilute or...
I get it. I get it. Here, I got it.
So we still have really poor flow distal. So what I'm going to do now is I'm going to have to capture this filter under penumbra suction. So where's my
retrieval?
my penumbra attachment? Yep. So we're going to turn it back on here. Continue to aspirate. Aspirating well. It is aspirating well?
Yes,
Yes.
it is.
Okay, so I'm just taking this wire into my filter here, taking the penumbra into the filter. Still aspirating well, Ray?
Yes.
Stop.
Okay.
Aspirate. It's aspirating.
Stop.
Stop now.
No?
It's
Nope.
dripping. It's
Okay.
dripping. It's dripping.
So I think I've got something stuck in my filter. So I'm going to walk this penumbra out now and see whether there's anything inside this device. I'm going to keeping my filter carefully in place. Careful. Okay. One of the things I want to do is check my pressure when I come out as well. Okay. Let me bleed back a little here. Flush forward, guys. Flush.
Saline,
Yeah.
coming.
Good. Excellent. Okay, good. Now let's see what we're doing with the bleeding up here with Ray. 1 second, Ray. I'm going to come toward you a little bit. Just a little dye for me. Just to see how bad this is. A little dye. A little bit more dye. Nothing bad, Ray. I think it stopped. Yep, it stopped. You're good. Yep. Okay, let's take, okay, it's going all the way there. All right, let's capture the penumbra now. Give me the, let's take a DSA shot of the foot, of the filter again. Ready? Inject. So you can see the column is right above the filter. So I have to try to capture the filter properly to capture all this, get it out. I want to make sure my penumbra wire is distal is good. My filter wire, and it is. And
Is that the filter
this
wire?
is what?
This is the bare wire.
Which is the bare wire? You got the bare wire?
Yeah,
Good.
It's the bare wire.
Okay, good. Load it.
Go ahead.
Capturing with the guide.
Yep. With the penumbra on. Ray, you need to come on the other side, buddy. And just hold pressure there just in case. Yeah, I would at this stage, yeah.
I'm gonna pull.
237.
I got the wire. I'm gonna pull the wire.
Okay.
You have the wire?
What's going on? I got the wire. Good. Good. When I ask you to turn the penumbra on, please turn it on. Okay. Turn it on.
One second. It's on. Yep.
Follow it down. That's a good sign. Off. Show me above, please. Turn it off, guys. So sometimes the suction pulls it up against the wall. So you have to turn it off and on. As so. Show me down.
On.
Not yet.
Okay.
Okay, now turn it on.
On.
Excellent. Good flow.
Slow. It's dripping.
Not good. Not great.
That's good flow now.
Okay. Captured. It just sucked it up. I'm going to leave the wire down. I'm just going to go down with this a little further. Show me down. Flowing still? Nope. Okay, so I'm just going to take it out now.
It's
Just taking
dripping.
it out. You saw everybody. Flora saved that, guys? Okay, good. So now give me, now empty the filter. The filter's stuck in there.
Make sure. You have to flow.
The filter's in the guide. Flush the guide out for the filter. Give me back the penumbra now. Give me the regular penumbra, Damien. Let's just see what we're dealing with. Okay. Actually, don't open it, Damien. We're good. Okay. Okay. So now let's see. Let's see what our situation is.
I don't see it on flash.
We'll use it to teach.
Fluoro it and see.
It's not there? Filter's not there?
Yeah, I flushed it. It didn't come out. So maybe you can just fluoro it.
Well, the wire's still there, so if the filter's there, it should be there. Okay, let's see.
Is the wire for the filter?
Damien, you're going to have to remove that penumbra bottle and see if the filter's sucked in there. I think that's what happened. Because our bare wire is still down, which means we could not have lost the filter. So one of the things that I want all of you at home to know is that you want to go ahead and check to see where your penumbra is. And so we have fantastic flow to the foot. So our penumbra worked, everything worked. So now the question is, what do you want to do? And this is what I got to talk to Atul and Ray about, because I think the issue here is, if we balloon, do we risk embolizing again? And do we need to put another filter down, which we may have to? I think it's reasonable to do that in this situation if we're going to use a DCB. I would give another 1,000 of heparin now, Liz. We're going to give another 1,000 of heparin. We're going to get another 4.7 Embo Shield. And then we're going to do the DCB. Can I get a 4.7 Embo Shield and a 60250 DCB?
DCB is right here.
So we're going to put another 4.7 Embo Shield down, and we're going to do the DCB on it. So you saw a nice technique of capture of the penumbra there, of the filter. And Damien's going to check our filter basket to make sure it's not missing. I don't think it's anywhere. I'll check my sheath now when Ray's here.
Yeah, I checked.
I'm going to mag up.
60250.
Yep.
Copilot should be there.
So what I'm going to do is mag up. You can let go, Ray. She's not bleeding. So we're just going to check to see if our filter is anywhere. Oh, that's DSA.
Yeah, I flushed it. I couldn't see it, but check this also. Yeah, check this.
Is that the filter?
Oh, the tube.
Yeah, it looks like the connection.
Not the filter, no. No, right?
I think that's the
That's
connection.
just the connection, yep.
Yeah.
The good thing is we've got our wire down, so we know the bare wire is going to capture the filter, and there is no filter in the body. We know that for sure. So it's got to be sucked into the penumbra, is what I'm assuming.
This
Okay,
came
good.
out, just came
Give me
out.
the new filter, please.
It came out.
It's out. So, huh?
It came out.
The filter's out.
Yes.
So we found the filter. Good.
And the guys?
So we can
just
call
came out.
Abbott and tell them
I
to
think you were
take off,
flashing it, right?
call
So
off the all
I
points
flashed it
bulletin
once
on the
again.
lost filter. All right, give me a new one, please. So now we're going to go ahead and place another filter down. And I think, everybody's got to understand that
Let me take this out.
the
the wire
SFA disease process is one that's very challenging. Atul and I have faced this multiple times, and through mistakes and and things that we have done without truly understanding it, I think we know that this is an issue. So this embolization would have been catastrophic if we didn't have a filter. So I think having that EmboShield down prevented this embolization. And now we also know that the process is ISR. Liz gave more heparin, and we're going to check an ACT again now. Ray's going to do that. And the reason we did this on heparin rather than Angiomax was so that we could have this, what's it called, direct SFA stick, and so it won't bleed. So now we'll go ahead, place the second EmboShield now, same spot like we did last time. Seemed to work really well for us. Thank you, Atul. And we're going to place it at this level. And then we're going to get the 60250 impact. And we're going to go down and balloon it. And again, we know we should have a little bit of extravasation. I hope we don't reopen that. But we'll see. Take it from there. So here's the 60250 impact going in. And then we'll take it down distal and take a look.
Liz, we need some more towels after you run the ACT. Thanks.
So we're just about done. Once we do the impact, I do want to tell you that we'll probably put a stent in the middle offline. I don't think I'll use a Supera here, just because I think that area is not well expanded. I haven't prepped it well, and she had a lot of pain. So therefore, I may just go ahead and put a Zilver PTX or a bare metal, since I'm treating it with a drug already. So now I'm just going to watch my filter as I take this down. We all know the impact balloon is a bulky balloon. So far, it's smooth. And as we come down to the distal stent, right there, I'm going to just pull it back slightly, get the distal edge right there. And then we're going to go ahead and leave this up for 3 minutes. Go up, guys, just phenomenal. There's our 250 stent. Yep, we're up to there.
Nominal 5.
Uh-huh. Ray, is there a hematoma in the inner thigh? I wonder. Okay. Go to 6. Okay, 5 is fine. That's where it is. That's where the bleeding is. Go to 5.
We're chasing 5.
Yep. I'll just leave it up at 5. Sorry, Mom. Sorry. Just leave it up at 5. That's very good. That's the overlap of the Supera, which we know is going to look like that. And we're going to leave it on timer for 2 minutes, please. So timer's on for 40 seconds.
Now, just in the SFA between the two stents, you mentioned before there was a dissection.
Well, because we did our dissection reentry techniques a couple of times.
Okay.
So we had to snare the wire. We did so many things different that I think this is an issue where, we're going to have to deal with it.
Right, but it wasn't a dissection before. It's what we did.
No,
Okay.
it's been while we were trying to cross.
Okay.
That's how it got started. So Atul, now we're going to let the impact do its work, hopefully. We've had some, everybody has that one anecdotal, but we had a few of them. I'm sure you do too. Long lesions, ISR, you do a balloon, a DCB, and it stays open a couple of years, and you're pretty amazed, right? I mean, in the past, we used to have to chase these over and over again, and hopefully, this will give her a little bit of symptom relief. The idea would be for us not to make it worse. Obviously, we're still not out of the woods. We still have a filter down. We're still ballooning. And, hopefully the ACT is a good level and we don't embolize again. But you have to be prepared to go back in with the penumbra, do the suction again, and then again salvage the vessel. So I think that, that's the only issue that I think I could tell everybody back home, that that's the key in these kind of cases. I don't know whether you have any pearls as well.
I think this is one of the ones where chance favors the prepared. You're prepared with the filter.
Yep.
We knew what we were getting into.
Yep.
The penumbra's here, ready to go. Everything was planned. You expected it. It happened, and you had a plan to get out of it.
Exactly,
So
I think you have to know that that's happening to you, right? I mean, you have to have an idea that this is going to happen, and that now we have to deal with this. So I think what we're going to do now is, as Dr. Kukar walks this out, we're going to make sure that the filter doesn't move. It still has to come down. So we're going to wait till everything comes down nicely. She has a little bit of tenderness right there. So I don't feel any real hematoma as such, but we'll take a better picture to make sure nothing is happening. ACT came back at 201. Can we give another 1,500 of heparin, please? And
would you consider putting a second wire down here and then a 014 for support?
I don't think you need it. This went down very nicely, so I wouldn't worry about it. I'm just going to go down and watch the wire for you.
Yeah, so now I think anytime I'm using, outside of these scenarios where you have a filter, when you're using a drug balloon, I'm usually switching to an 035.
Oh, I agree with you.
I think you have
a very good point. I think you have a very good point. So I chose an 80, a little bit longer than we want, so we don't have any geographical miss, right? So now as Dr. Kukar comes out, I'm going to go ahead with my 80 balloon, so I don't have any geographical miss. Another 2-minute inflation, and then hopefully we don't have much embolization. And we'll be done. Okay, Rail? Great. So again, I'm going to go up here. So we're going to go in to this level. Fantastic. Let's go up.
I think one of the important things here is, we know the drug-eluting balloon, that the drug's gone in 3 minutes.
Right.
We want to deliver to the lesion within 30 seconds and inflate and get up against the wall.
Yep, 5. Yep, that's great. So we're going to leave it up now for 3 minutes.
So, PK, I think one of the big things in this case is her smoking.
Yeah.
So,
yeah. I mean, that is a major issue with a lot of our patients. They, for whatever reason, seem to, don't seem to understand, or it's a very difficult, addictive thing, as we've all know about smoking. And I think that, the support system and the constant reminders of you and me and all our team in talking to the patients is huge. So I definitely agree with you. I think you're right. You can do all the wonderful interventions that you can, different access points and all that. But if you're not able to really, modify their risk factors, it's gone. The other question is whether you would use a NOAC in this case. I'm not certain.
You read my mind on that one. I think I would.
I think possibly, right? Yeah. Maybe Plavix and a NOAC, a low dose NOAC might be useful, because we do know there's a thrombotic component. There's poor flow in the SFA. But with this, with the suspicion of a perforation, I'd probably wait till tomorrow, do a ultrasound to make sure there's no frank hematoma or anything like that. And if there's not, then we'll go ahead and give her a starter on a NOAC and Plavix.
Now, one of the things I've been doing for these patients is I've been actually giving triple therapy for 2 or 3 weeks.
Sure.
And obviously there's no data for or against that, but in a low bleeding risk, we use some of the coronary data to estimate bleeding risks, and then we
the Has-blood scores,
yeah.
And I think all those things we should do that. And I think that also helps us know how aggressive we can be with our anticoagulation. But we do know that more and more that I think aggressive anticoagulation in a balanced manner likely will prevent some of these lesions from thrombosing. And especially with drug-coated balloon technology, I think, and drug-eluting stent technology, even though the clinical trials haven't shown a higher thrombus risk, there is theoretically a higher thrombus risk. So I think we have to be careful. Down, guys. So hopefully now we'll be done and we'll go offline and do the stent. I just want to make sure my filter is good and not full again. And then Atul and I will take a picture, and then what we'll do is offline put a stent and be done. But we really wanted to show, a case where within an hour and 10 minutes or so, a total SFA that we failed, that our colleagues on the outside had also failed, that clearly, had a lot of technical challenges to it. Again, as you can see, as experienced as we both are, we want to watch the filter as we come out, because we know that if that filter moves, we may spill stuff distally. Please don't be nonchalant or casual about it. Understand that this is a very important step that Dr. Kukar is demonstrating, showing the discipline that he has in making sure that there's no issues with that filter moving or the wire coming back and dislodging the filter. This is obviously an advantage of this filter. Obviously, the EV3 filter is large and the porous, so that's also good. So I'm just going to make sure I just bleed back a little bit just to make sure we don't have any issues going on. And we'll take it from the, can I have a syringe? Here's a syringe, great, thank you. So make sure we're good, flush forward, thank you. So hopefully on the DSA we'll be able to show that this filter looks good. All right, inject, and don't be surprised if it's not. We might have to deal with it again, it's okay. We'll deal with it again, and that's what we're used to see. And there it is, and we have embolized again. Not as much, but we clearly have embolized a little bit. So we will suck this out under penumbra guidance, and I just want to make sure we haven't perfed anything here. And then I'll tell you what we're going to do to this area. Inject. So we have a little bit of a recoil in that mid area that we will go ahead and re-balloon it. And then we'll go ahead and stent it. So while Ray and Atul get started with this, I just want to go over a quick summary of what we've done. Ray, can you go ahead and penumbra it? Can you guys focus the camera on me, please? Yep. So as you see, this is a novel way of crossing on a restenosis. This is not something that myself or Dr. Kukar would suggest that all of you do for every ISR case. But it's important to demonstrate newer access techniques in being able to cross these stents. So it's very important here right now at this stage to say that, okay, we've crossed this, and now we have to understand that once we cross it, what is the morphology of the lesion? There is a thrombus burden in these lesions, and because of the thrombus burden in these lesions, it's important to use a filter, which we went ahead and did as well. We also demonstrated the utility of the EmboShield in particular in this case, but obviously if you don't have an EmboShield on your shelf, you can use any filter at all, because I think that these filters, especially the two FDA-indicated filters, work very well in preventing distal embolization. We also showed the technique of using an aspiration catheter with the penumbra, using a coronary multipurpose guide to be able to aspirate the thrombus out. We were on heparin because of the fact that we were worried about the clot, the stick that we did in the SFA. But however, we're chasing the ACT now to make sure that it's up. So Dr. Kukar, now offline, myself will go ahead and aspirate this. Then we'll put a bare metal stent into the mid segment of this lesion, and then we'll go ahead and finish up with a balloon angioplasty of the prox, all under filter guidance. After which we'll just go ahead and put this patient on dual antiplatelet therapy. Doesn't look like there's a perforation, and after which we'll follow her closely. Smoking cessation is incredibly important, as Dr. Kukar clearly talked about. Once the smoking cessation is done, I think the patient will also hopefully have a prolonged patent period without significant restenosis. So on behalf of my dear friend, Dr. Kukar, and our team here at Sinai, we appreciate you tuning in and watching this great case. It's a 1 hour and 10-minute demonstration of a pretty complex lesion with access points and management of thrombus. So I appreciate it, and we will see you in December. So thank you again, and have a great day. Thank you. All right.